and she came in, and she was about a month of age, and she was pretty hurt when she came in. Um, and she had multiple fractures, a femur fracture, rib fractures, skull fracture, and then they eventually chose us, and that's how Katie became part of the family.
Hey everyone, welcome to another episode of HUMED. I'm incredibly honored and delighted to have Dr. Ron Turker with me today, former colleague of mine when I was tiddling around the halls of Oregon Health and Science University as a peds ER physician. Ron is a friend and also an accomplished writer. He just published a book within the last year called The Wandering Jew of Saint Salacious. He started his career as a pediatric orthopedist, who are our friends. We're all friends with our pediatric orthopedics and pediatric ER. So he started his career at the University of New Mexico and then spent time at OHSU and also Shriners Hospital, which is really beautiful work taking care of children of need with orthopedic issues, and then spent really close to 16 years working for Kaiser Permanente in Portland, Oregon, but still working very closely with the physicians at OHSU, taking care of pediatric orthopedic emergencies. He is an advocate of many things and a former comedian, or maybe he still is a comedian. And seriously, Dr. Turker, it's an incredible honor and privilege to have you on HUMED.
David, it is great to catch up after all this time.
So I would love to hear a story that you want to share with the audience. First of all, it's been great to catch up, and part of the journey of HUMED is catching up with old friends and meeting new ones. And this has been really wonderful getting to catch up with you and hear all the awesome things you're doing, which we'll get to at the end of the show, I am sure. But share with us your story.
Okay, well, I first had to get permission to share this story. Okay. Because it's partly my story, but it's really a story that belongs to my daughter. And so 20, oh gosh, how old is she? She's going to be 25 in a couple of weeks. So almost 25 years ago, we met, my daughter and I. You were there at that time. You were at OHSU at that time, Dornbecker, the kids' hospital. And I met her first in the emergency room. And she came in, and she was about a month of age. And she was pretty hurt when she came in. And she had multiple fractures, a femur fracture, rib fractures, skull fracture, and she was underweight, a little dehydrated, etc. And that was not unusual, right? I mean, like you and I have dealt with over the years, many kids who have gotten hurt in the care of others. And truthfully, and I don't know how you feel about this, David, but for me, at some point in my career, early, I kind of gave up the judging part of that. I just was, I was definitely more intent on taking care of these kids, number one, making sure they were safe, number two, and that kind of outrage that I had early on dissipated when I realized, well, I mean, people were, we're under all sorts of stress, and you can never tell how you'll act in a certain situation. And so, Katie was one of these kids who came in, and we started taking care of her. And then because she had not just these fractures, she had dislocated hips, she became more of a more kind of chronic patient of mine. We were taking care of that, and she's had multiple surgeries and so forth. Um, and then it's around a year of age, when I had kind of been working with her for almost that whole year. Um, One time when I walked out into the waiting room to speak to her foster mom, and to her care worker, her caseworker, for the DHS, the Department of Health and Services, and let them know how the surgery went. And then I asked, so when is she going back home? Because the usual course for these kids is that the parents get some kind of training, they get psychological counseling, et cetera, et cetera, and then the eventuality is that they either go on to another family member, get adopted out into another part of the family, or they go back home. And the caseworker said to me, well, she's more than likely not going home, um, because there are issues at the home that have not been resolved, and so she's more than likely not going there. And then she said, well, do you know like any good families who might want to adopt her? And I said, no, but I'm sure you'll find plenty of people who want this beautiful baby to be part of their lives, and yeah, I'm sure you'll find someone. And I walked away. And as I was walking away, she said, can I ask you another question? And I said, sure. And she said, well, we're looking for a special family for this one, and she's going to need a lot of care. And do you know anyone like that? And I said, no, but if I think of something, I'll let you know. And then I walked away again for the second time. Went to the locker room to change out of my scrubs. Had to get to clinic. Busy day, and I'm in the locker room changing, and gosh, it hit me like a ton of bricks. And I can't tell you why, because again, I've taken care of so many of these kids. I never, ever, ever thought about bringing them to our house and bringing them into our home and our family and our lives. But there was something special about this kid. And so there's that wall phone in the locker room, right? With the cord and the coiled cord and everything. And I pick up the phone. It's in the middle of the day. And I called my wife, who, wasn't available. And so got the answering machine, which back then we had. And I left this rambling message. And I think I started off with something like, okay, I don't want you to think I'm crazy or that I'm joking around. I'm being serious. And then I gave this whole story about this kid that I had been taking care of, et cetera, so forth. And I hung up the phone and went on to clinic. And somewhere in the middle of clinic, I get a call. And I pop into my office to grab it real quick. It's my wife. And she goes, are you out of your mind? I was like, well, I knew you were going to say that. And she goes, what are you talking about? And I kind of went through the whole thing again, the same story. And she goes, I don't. And I said, well, she's going to be in the hospital for a couple of days, because we just operated on her. And so she'll be here for a couple of days. It's like, I don't know if you maybe wanted to come in and visit with me, when I go do rounds or something, and you could kind of like, go meet her. And she said, like you meet a puppy at the pound? And I'm like, no, but I can see why you're saying that. And in any case, we had another discussion that night, and she said, you're serious? And I was like, yeah, I'm serious. And so it didn't take long for Colleen to kind of like jump on board with me. And the next thing we know, we were taking classes through the state, for, prospective adoptive families, and having home visits and working with the Boys and Girls Aid Society and so forth to be vetted. And then we were in it. And for the next year and a half, we were in the running with two other families to see who would get to adopt her. And then they eventually chose us. And that's how Katie became part of the family.
Wow, that's such a
Yeah.
beautiful story. So, at that point, did you have other children at home? Uh,
Yeah. My son, Benjamin, who was, when we were going through the home visits, Ben was probably 4.5, something like that. And I remember this so clearly. We were sitting, Colleen and I were sitting on the porch talking to the caseworker who was evaluating us. And then he just sort of toodles in to the conversation, and without any prompting. And I have no idea to this day what he was thinking. But he comes outside and he says to us, "Hey, Mom, Dad, I found this quarter. I think I'll give it to charity." And walks away. And, and we both looked at the caseworker and said, "We didn't set that up." That was, we weren't really kind of like pleading our case here with him. But in any case, yeah. So Benjamin was about 5 when she finally came
mm,
to live with us. And we became her foster family first.
wow.
Yeah.
So, tell me a little bit about what about Katie. We do see patients all the time, and actually, because we're human, there's some children and families I connect with in any given shift in any given year that just happens. And, a couple times I will admit I will go to the hospital and follow up on some of my children. And it's not because I'm medically curious these days because of the electronic medical record. And I can always sort of find out what has happened because it's important from an educational standpoint to do that as an ER physician. But I will go and visit the family because something about our interaction was very special. What about your interaction with her? And because you had met her at 1 month, and I'm assuming she had multiple procedures because
Yeah.
she was severely battered. I'm assuming when she presented to the emergency department at 1 month of age. What about your experience with her separated her from the other children? Can you name that?
Yeah. So I don't know if it was something innate in her, um, but or if it was just a survival kind of survival instinct of hers. So there she was. She was living in a foster home, and then her foster mother was one of these foster moms who takes care of medically fragile kids. So they're always in high demand. So there were always, kids under 2 that are being cycled in and out of this house, and lots and lots of kids that she took care of. Katie always seemed to, when she came into clinic, there was something about kind of her smile that would light up the staff.
Mm.
For me, I was a little more distant. I mean, I had, kind of that, just a more, oh, I don't know, just a more objective way of kind of looking at the kids and dealing with the kids just to make sure that I wasn't missing anything in their care and treatment. Um, but the staff would just, like, when they would see her name on the schedule, they would just go, "Oh, Katie's coming today. Katie's
Mm.
coming today." She had a beautiful smile. She just interacted, so wonderfully as an infant with all these people in my clinic. And I think, maybe if you're kind of vying for attention in a household that has a constantly shifting landscape and there's 3, 4, 5 kids at the same time, all needing attention, it just serves you to just have kind of that winning smile, that winning attitude. And I will admit, maybe cry a little bit harder than
Mm.
some of the other kids,
Mm.
because she had that going for her too. And so, yeah, I think that she just had a way of brightening up the people around her.
Mm.
Very engaging baby.
When people ask me what I do, I talk about it, and it depends on who the person is, and to try to describe what I do as a pediatric ER physician. You said something to me that was really important and resonated, which is that you maybe I don't I want to talk about this, but you had said something to the effect of I'm not angry at these people anymore when I see children who are abused, or you have less judgment. And I really resonated with that because when I first started in my career as a young attending, I would see children who were abused, and I knew that they were abused. And I was with the family at the time, and I would have some emotional reactivity to that situation. And now at this part of my career, I try not to have any judgment, and I don't think I do. Maybe I do, but if it is, it's very subconscious. But I would love for you to talk a little bit about that, because you have seen a lot of child, and you not only see oftentimes these children acutely, perhaps when they come into the ED with femur fractures and other things, but you also follow up with them in uh, in clinics, so you get to know them a bit. So can you talk a little bit about the judgment around children who are abused?
Well, okay, so you and I, um, we started out, in a similar place, and then we've had kind of similar careers. We're both kind of Long Island boys that grew up and moved out and started to see the world in a different way.
To the
Um,
diaspora. Yeah.
exactly. And so my first taste of how the world really worked was when I ended up in a residency in general surgery before I did orthopedics on the south side of Chicago. And it I wasn't there more than a few weeks on the trauma service, and I couldn't believe what I was seeing. I
Mm,
couldn't believe the level of violence and
mm,
the level of trauma. Um, and yeah, it's easy to judge, coming from a place where I always had a sandwich, in my lunch bag, and I was like, you know, angry at first, and just like appalled, and it's hard. It's hard not to it's hard to put away those judgmental feelings. But those kids, and they were kids on the south side of Chicago, these 15, 16, 18-year-old kids, 20-year-old kids, slowly they taught me, you can judge, but you don't know my life.
mhm.
You don't know. I remember David had some kid gunshot wound to the abdomen. He was 17. This is early on in my career there. And I was literally pushing him up these ramps to get to the operating room. And the emergency room was like 3 city blocks from the operating room. And I'm there in the hallway by myself pushing this kid to the operating room. And he lifts up the sheet and he looks at his belly and he says, "Shit, man, another summer with a bag." And it was almost like I almost stopped in the middle of the hallway, and I'm like, oh my God, he knows exactly what we're going to do.
Mm.
He knows he's going to get a colostomy. He knows this. And he's 17. I mean, I was probably, what was I, 26-year-old kid? I was just sort of like, uh, you know, it's not so easy to judge someone who's seen things that I'd never ever ever seen. And that was the beginning of kind of an education that was so raw, um, and so vital to what we do.
And it's really not only just an education, but it's an awareness, right? That maybe we didn't have as children growing up in a more protected environment. I remember when my grandmother, she would take me into the city to see Broadway shows from Long Island, and we'd take the train in and be walking on the street. And I remember her saying, looking at homeless people and her having extreme disgust and judgment, drug addicts and bad people. And maybe she didn't say everything, but that's my memory as a child. And then I found myself in San Francisco taking care of these people as patients, and they were human beings, and they all had stories, and they all had very sad stories, many of them, and difficult situations that someone with privilege could really never fully grasp until you're actually in it. Um, So tell me, getting back to Katie's story, tell me a little bit about what it was like raising. I want to be sure your other child is you had biologically. So tell me a little bit about what it was like growing up from the age of 4 and 1. You had a 4-year-old son and a 1-year-old daughter after you went through the adoption period. What it was like having a biologic child and an adopted child, and then an adopted child with who came into life with a lot of trauma in the first year of her life.
So I think before I dive into that, the one thing I want to emphasize is the word story. Everybody has a story. And I think that's the place where every doctor, nurse, tech that takes care of people, it all starts with a story. And when we don't know each other's stories, that's where distrust comes in.
Mm.
So I'm glad you brought that up. That it is about story, and that part I'll jump back into our story. Once Katie came to live with us, so first of all, with complete kind of hubris, I will say that raising Ben was like raising a Labrador. You just throw the ball, and throw the ball until he gets exhausted, and then he just would go to sleep and start the next day. He was easy, um, and we'd look around, Colleen and I, at our friends who were having struggles with their 4-year-olds and 5-year-olds, and we'd be like, wow, we're really knocking it out of the park here as parents. We're pretty good at this, right? And then Katie came along, and she became part of the family. Um, Man, I'll tell you, like Katie knew me,
Mm.
but she knew me in a different context for a year and a half. Like she came into the house at 14 months of age as our foster kid. She took right to Colleen. She would not have anything to do with me. She would scream when I would come in.
Wow.
Mhm. Um, Even when Colleen would mention, dad this or dad's home or dad, and she would just scream. And
Do you think that was a trauma response, perhaps?
oh yeah,
Mm.
yeah, yeah. No, she definitely kind of connected me to a lot of what she'd been through, and with due cause. I mean, fair. Um, and so we had gone from kind of like child rearing 101, and then the next thing you know, like we're involved in like the 444 class where you got to get the professor's permission, and there's prereqs and all that. um, it was hard, and like one of the things early on that was a little bit of a trick that Colleen used that worked was she, instead of using, like, so Ben called me dad, but that triggered Katie. And so Colleen changed it to Papa. And just changing the name seemed to kind of change her identification of me in a way, and that kind of helped. Um, and so it was, we were raising two kids on two different tracks. Now, you know, I'll tell you that we've talked to so many friends and my brothers and so forth. None of these kids, biological or not, get knocked out of the same mold. They all come with their own kind of personalities and their own kind of strengths and weaknesses, etc. Um, but knitting this family together from a different place was interesting. It was hard at first. It was trial by fire, and it was learn as you go. Um, and we learned, and in the end, there were some real rough spots where you know we had to learn to handle the two kids differently, really differently.
Mm.
um, Not to have similar or the same expectations of the strengths and weaknesses. And I think every parent has to learn that. It doesn't matter, adopted or not. But Katie came with a lot of trauma, had difficulty with attachments um, early on, and for a good period of time. Um, it was hard for her to bond, I think, at first. I don't know. How do you learn to trust when trust was never in your, in your purview? It just wasn't there, right? I mean, like, I don't know. An infant, when they cry, people say, you can't spoil an infant. You can't spoil a newborn. Pick them up, pick them up, pick them up, hold them. And
Infants need that human connection. And in fact, there are classic. There's some studies done before, I think, IRBs and ethical committees, but there are known studies when children were put in hospital beds in the 1920s or earlier, and they were separated from their families, that oftentimes infants could die because of the lack of human connection and human touch. It's actually so interesting. And on the other end, we're learning in terms of the longevity community, we're learning that one of the number one reasons why people stay alive and have high quality and high quantity of life in their 70s and 80s and 90s is the idea of human connection, being a part of a community, being loved by your family. Men who are alone die early, and women too, but men even more likely to. So um, we're made to be social animals, where
yeah,
it's all part of the story. What are your thoughts about that?
yeah, no. So for I don't know. So 300,000 years of our existence, right? We, the upright kind of monkeys, with the big forehead and opposable thumbs, and we lived in bands of 50 to 150 people,
Yeah.
and we were in community. And without that community, um, you didn't survive. Every member of that band was an investment. Every member contributed. So we're, for 300,000 years, we're kind of doing that. And then in the last century or so, century and a half, well, I mean, we eventually kind of built larger communities once we learned how to cultivate crops and things like that. So, goes back 10,000, 12,000 years ago. But even then, as the communities grew, um, those bonds stayed really tight. The human to human connections. People slept in the same bed. They shared clothing. They shared space. Um, but we, in the last century, and especially the last 30 years, 40 years, we've come to prize our isolation, our distance from each other, our distance from our neighbors, um, as being kind of having made it, having to have your own space. And I'm not sure that hasn't been to the detriment of society. I think that we're made to be in community. We're made to breathe the same air. I think COVID showed us that,
Mm.
right? Like, you and I are talking at a distance, thousands of miles, which is beautiful. It's a wonderful technological tool. It's fantastic that you and I can reconnect like this, right? How wonderful. By the same token, I think if you and I were to kind of continue on with this friendship, eventually we'd want to kind of share space. We'd want to share a drink. We'd want to share food, um, breathe the same air. And that, I think, has been something lost.
Mm.
The idea that we can kind of um, hold community at an electronic distance is something that I think it's a fallacy we'd like to kind of sell ourselves and buy at the same time, and one that has so much peril just knitted right down into it.
Yeah. I think that you may know this, but there's very, very provocative data that during COVID, the rates of mental health issues for children and showing up to the emergency department in mental health emergencies tripled. Not 30% higher, not 50% higher, but 3x. And what's really interesting is that that rate has continued. It hasn't dropped down to pre COVID uh, rates. And I have some theories about it, but I think um, my theory, just David Spiro's thought, is that it has a lot to do with social media. I go to a studio here in Little Rock called Numa, and it is a yoga studio. And I'm sort of the old person there. It's mostly kids in their 20s that show up, and there's no communication. Everyone gets into class, and before class, they're on their phone, and I'm just sitting there trying to be in my own space and on my mat. But uh, there are a couple of older people that I've gotten to know, and we connect and we talk a little bit before class and a little bit after class, and it feels like a little community. But most of the other people just show up and they're kind of in their zone and on their phone. And I don't know if that's part of the contribution of why the rates of mental health issues have continued. But the idea of this podcast and the idea of what you just talked about in terms of human connection is something so integral to, I think, the health of us as humans. And it's even more important as we delve into this new phase of our world where artificial intelligence is coming to us, and it's really hard to figure out what's reality and what's not reality. What are your thoughts about that?
Well, first of all, I think that COVID COVID peeled back the superficial, um, covering on top of it. Basically, it was a little bit of a veneer of what society was. I agree with you that social media has been incredibly unhelpful. So over the 30 plus years of my career, I watched rates of anxiety and depression, major depression, suicidality in my practice, um, in my orthopedic practice. So I had two practices. Toward the end, I ran a pain clinic for
Mm,
kids
mm,
for the last 7 years of my career, but I also had my orthopedic practice. But even in my orthopedic practice, the rate of suicidality just it blew me away that I
mm,
was losing kids, and it wasn't every day or every week, but a couple of years enough, right? I mean, like, to say that something is very wrong here. Um, and so these kids that were having increasing anxiety and depression and inability to kind of communicate, I agree with you wholeheartedly that our pocket computers, um, loaded with these social bands that are artificial, are unhelpful to say the least, if not really pathologic. What was it when you and I were kids and you had a bad day at school, right? Somebody is just giving you crap, and you're like, and you get home, and I would march up the stairs to my room. I would close the door, and I would turn on the little stereo I had, and had these little tiny headphones that were crap, but they were everything. And I'd listen to some album. And I was there and I was alone and I could work things out. And then I kind of emerge and then go back to, being with the family, my brothers, etc., my friends. But what happens when you're having this jeering crowd at school? Just, I'll use the word bullying because it seems to be a common word. What happens when that crowd follows you home in your pocket and
mm,
they're still hammering on you, and they follow you up those stairs and they're still hammering on you, and you slam the door and you close the door and they're still right at you, kind of like, on Instagram, on this, on that, and just kind of, tweeting and messaging, et cetera, where you can't get away from it.
yeah.
And it's so much easier through our thumbs and our texting and electronics, instead of being face to face with someone and to say, you know what I think about you? I think this, this, and this. To do that to someone's face takes courage. To do that with your thumbs, there's no courage in that.
Hmm.
That's just reaction.
Hmm.
And so when COVID happened, it was an interesting thing because at the very beginning of the lockdown, I went into the office and I started calling all the kids on my pain clinic list because they were the most fragile kids of all of them. these kids in chronic pain. And I go, hey, how you doing? You doing okay? You doing okay? And I got this shocking response from them. They would say, doing great. Because I thought these kids locked down are going to be just, so much worse and so much more pain and having so much more anxiety and problems. And I was like, what? And they're like, yeah. You know what? Now, all those kids in high school, all those kids in middle school that were bullying me, all those kids that kind of like thought they were all that, now they have to stay in their houses too. They can't go out either. Now they know what it feels like to be like me, that I can't leave my house. That lasted about 2 to 4 months. And
Very
then
interesting.
after that, then the kids really started to suffer. Those kids, my chronic pain kids, really started to suffer. But I just was amazed. I was like, this doesn't make. What am I seeing? And then it made sense. I was like, sure.
So
Now other kids knew.
we never talked about this, but for those of you that are early learners or not in medicine, very often physicians get into pain medicine through the field of anesthesia. And I would say it's unusual for a pediatric orthopedic physician to get into uh, and develop his or her own pain clinic. So I'm just curious what inspired you was it a bit of Katie's story? Was it, what inspired you to develop an expertise and develop a clinic in pain?
I'll tell you what it was. It was seeing in my own hand, with my own hands, in my own practice, and in the practice of my partners and colleagues, so many procedures that were so they were they were worse than worthless. They would cause more problems than solve. Things like, oh gosh, knee scopes for teen girls with knee pain that just wouldn't go away, right? And there were studies that showed us knee scopes for teen girls that anterior knee pain that won't go away are useless. Realigning their patellas, unless they truly are out of place, was worthless. And oftentimes it would flare up this kind of cycle of chronic pain. Um, and this is going to be controversial, but exercise-induced compartment syndrome of the calf, right? Yeah, probably exists, in a very, very small number of people. But I would see people release those compartments, and then these kids would come back, and the wounds wouldn't heal, and the pain was off scale, and they'd end up in wheelchairs, et cetera, et cetera. I When I started out as a resident, I remember a kid coming in with what we then called reflex sympathetic dystrophy, with the red, swollen leg and foot and ankle. And our our professor brought a group of residents in with him and students and said, "You got to look at this. You're not going to see this very often in a child." And it was early on called causalgia. And basically, this was a stress-related, anxiety-related, stress-related condition with physical manifestations where bones and calcium would be washed out and bones would fracture. I mean, you can talk about it's all in your head, right? But the reality is that's where we live. And that head, that brain controls it all. And all our physicality starts there. And so when things break and things go awry and your immune system's not working, you know, that there was something bigger than just a simple cascade of chemicals, a simple cascade of cells not doing the right work. There was something more to it. And I could no longer contribute to that.
Mm.
I just was like, I started to identify those kids when they would come into clinic early. Instead of coming in at 9 months to a year with the osteopenic calcium, loss in their legs and sometimes in their hands, but with kids, it was usually foot and ankle in my clinic. Also associated with migraines, associated with the chronic recurrent abdominal symptoms, et cetera. I mean, like there was something that was that was tying them all together. And I just couldn't be part of this. Well, I'm a surgeon, I can reach anybody's pain with the knife if it's long enough. Because it's not true. And then I would see the kids getting bounced. Well, go see this person, go see that person, go see there, go there, go there. It's like a moonscape with a bunch of craters and a doctor sitting at the bottom of each of these holes. And then you basically throw the patient up along the landscape and they bounce around until they land in the next hole. And hopefully that doctor will take care of them. But, honestly, you know how it goes. They just cycle around. And where do they end up? The emergency room.
Oh,
Over and over and over again. And I'm like, enough of this.
and by the way,
So,
when many of these children become adults, they end up becoming addicted to opioids.
right.
And we prescribe them, which is part of the opioid epidemic is due to the fault of physicians. And I remember 20, 30 years ago, there was a push in emergency medicine to improve patient satisfaction. And did we prescribe enough pain medication? And then it went the other way. It was just like, okay, you can only prescribe 5 oxycodone pills, or now let's try ibuprofen. They really don't need oxycodone. But so what percentage, here's a crazy question. What percentage of pediatric orthopedic surgeries in the United States, just a Ron Turker guess, what percentage of surgeries do you think are not necessary? 5%. Are we talking about 5%, 3%, 1%, 20%? What's
You
the Ron Turker
hesitated.
answer?
You hesitated before you said not necessary. It was like, it was hard for you to spit it out. But I knew where you were going. Um, what percent in pediatric orthopedics?
Yeah.
Um, I'm going to go with a low number. I would say in pediatric orthopedics, like 15, 20% maybe tops are unnecessary.
Wait a second. That's not a low number. That's
It is
one out
a,
of 5.
yeah.
But
Yeah.
you would say it's higher in adults?
Yes.
Hmm.
Yes.
The
Yes,
reason
for
why I
real.
said that is I almost went under the knife in Portland. I ended up having a meniscal tear and having surgery because it just didn't go away. But for 5 years, I put it off fine with physical therapy. And there's been some studies that there was actually a very famous study in the New England Journal of Medicine that randomized adult patients with meniscal tears of the knee to either getting surgery because there's a tear and you see the tear on MRI and physical therapy, and the outcomes were similar many years out,
Yeah.
which is shocking, right? But folks are still getting surgery for meniscal tears because it. And again, you're the orthopedist, but it seems to me that if you look at MRIs, there are going to be issues with everyone's knees and joints,
Yeah.
and then you have pain there. But just that doesn't mean that you need surgery. There are other modalities that support uh, the injury outside of surgery.
So
But you
what did
think
they
it's
teach
higher
us?
than in adults? I'm curious.
Oh yeah, it's higher in adults.
Uh-huh.
I think there is an inherent self-selection of people that go into pediatric, and then fill in the blank next to it, right?
Mhm.
Pediatric emergency medicine, pediatric gastroenterology, pediatric neurosurgery, pediatric orthopedics, right? Um, which, by the way, is a little bit of an oxymoron because orthopedics means straight child. It was derived from taking care of children. So I think the adults should have to kind of hyphenate their name. But in any case, I digress. I think that people that self-select themselves into pediatric specialties tend to have, and I think this would bear itself out if you try to do some sociologic study. They have softer edges. They have more hesitation. They have more. Gosh, they have more introspection and doubt about, am I doing the right thing? Am I all that? Especially in surgery, right? I mean, orthopedic surgeons, we're known for just sort of, um, not always right, but never in doubt. Um,
Mhm.
and and I do think, it's where you put the incentives in medicine. If you put the incentives in a place where if I just do more to my patient, I will get reimbursed more. We can argue whether that's kind of oversimplifying things. But in general, that, I had a chairman once tell me, Ron, surgeons are like rats. They'll go where you put the cheese. So if you have an incentive that's always lying over there, to the east, um, you're eventually going to kind of migrate in that direction, even though your true north is pointing a different direction.
Yeah.
You either bend or you eventually break. These surgeons are coming out owing hundreds of thousands of dollars in their mid 30s. They have a mortgage before they ever have a home. And if you go to conferences and you have, 200, 300, 500, 1,000, 10,000 orthopedists all kind of nodding, kind of going, yes, that's the right way to treat that patient. We're not immune to the herd mentality.
Yeah.
Yeah, that must be right. I mean, it's published in journals, for goodness sakes.
Well, you're bringing up so many interesting things, and of course, at a higher meta level, there is no way in the United States of America we'll have the same kind of healthcare system that we have now, because in 10 years, 20 years, whatever the number, we're going to go broke. And what's interesting is that it's very clear that we spend more per capita on healthcare than any other developed nation in the world, and our health outcomes are one of the worst in terms of the developed. So we're not there. There are many good things about our healthcare system, and there are many, many challenging things. So I want to wrap it up with two. I want to get back to Katie at the end, but I do want to talk about something that's important to many people in the HUMED audience, which is what happens towards the end of our careers. And just like when we were growing up and we had sandwiches, as you mentioned, and we had some degree of privilege, we have privilege as physicians in 2026, and you have lots of choices and you're fortunate, as many of us are, to have choices when you wean down off of clinical practice and get to do some things that that really move you in your heart. And I would love for you to share a little bit with the audience what's meaningful to you right now in your career. What is moving your heart? What are you thinking about that you want to do that's going to make a difference for others?
It's my time, and what fills my heart is paying back what I was given. My students, my colleagues, my younger colleagues have gone off, into their practices, and they don't have the career path that I had. They're really under so much pressure. So, we're under pressure every day in taking care of people, right? I mean, that's a complicated thing to do. But when you add the pressures of an insatiable beast that is basically telling you, no, you have to practice this way, you have to do this, you have to do that, and in your heart you know it's wrong, but they're being kind of locked in this path. If your true north is this way, and there's some corporate magnets sitting off to your side that's saying, no, true north is over here, you will either bend or you'll eventually break. My goal now is to elevate the conversation with the public, with our colleagues, to help them unlearn learned helplessness and not say, what are you going to do? They're too strong, they're too powerful, it's too big, what are you going to do? It's really time for us to, as you said, it's time for us to awaken to the fact that despite the fact that we spend twice as many dollars as our nearest, competitors, if you want to call it that, our nearest neighbors, around the globe that have similar wealth that we do, and have results that are 50th, 60th down the list of global countries that our outcomes of maternal fetal mortality, life expectancy are so much worse, and yet we spend twice as many dollars. It's time for us as a people to have the conversation. And so through my writing, through advocating for, like, we have this weekend a film coming to Portland that I, you meet all these people on this healthcare reform kind of platform where I'm meeting people around the globe, where even other countries for sure want to do things better and better. Um, when you could elevate that conversation to the point where it's a tipping point where we can get the public to reconnect with us. We have lost their trust, again, exposed by the pandemic. For 20 years or so, we've made it harder for them to call us, harder for them to get an appointment. We're bankrupting half of the personal bankruptcies in this country. More than half are related to medical bills. Um, like when the pandemic came in and we stood up as the medical community and we said, listen to us, we'll help you get through this. And they looked at us and they said, aren't you the people that I couldn't get an appointment with for 6 to 9 months? And when I got in the office, you gave me 6 minutes. And then when I said I had another problem that I wanted to talk about, you said, make another appointment. And aren't you the people that sent me those 3 letters that said, this isn't a bill? And then the fourth letter was from a collections agency. Aren't you those folks? And then
Mm.
they said to us, no thanks, we'll do our own research. And that, I believe, is part of how we got to where we are today.
In
And
terms of
so,
the misinformation that the public has.
because they don't trust us,
Hmm.
and we haven't given them reason. So I think that with the writing, with the movies, with anything we can do with social media, etc., to reconnect, to have the conversation. Um, I think I told you. So we're bringing this movie called "Suck It Up, Buttercup" to Portland this weekend, and it's really a movie about it's a documentary about moral injury in healthcare workers and the burnout, and it's a way of kind of showing the public, we, as to where we went and why we're not there for you. This is a big part of the reason we're getting crushed, just like you are, by those insurance companies, by private equity, by all these people that just are avaricious and take and take and take. We're all in the same boat. We just didn't realize we were in the same boat. So yeah, so through The Wandering Jew of Saint Salacious, my goal there was to not write a Atul Gawande style, nonfiction, which is he just, writes these beautiful books. Victor Montori's book on Why We Revolt. And I mean, these are just brilliant books. I'm not brilliant, but I
Oh,
am
yeah.
funny.
You are funny and you're brilliant.
And so I figured, well, I could just go with fiction and make it funny, but
Mhm.
there's a message at the center of that book wrapped in just a humorous capsule, and it's easier to swallow than some of these other books. That's what I want to do. That's what keeps me going.
Mm.
That's why I wake up sometimes at 3, 4 in the morning and I start writing.
So, just a quick pivot back to Katie. Can you let the folks know? I mean, that was such a challenging beginning she had with her life, and then a beautiful story about the adoption and how she became a part of your family. Now she must be close to 25. Is that correct?
Yeah, she's going to be 25 next month in 2 weeks.
Mm-hmm.
And she is amazing. She has had her challenges, and she still has her challenges, and we have settled into this beautiful relationship. I mean, so many parents will tell you that the kids, when they hit their mid 20s, they're just, they come back around, and then everything is like just so tight. I've never felt closer to her. I truly believe that she's never felt closer to me and to
Mm.
Colleen. We are so there for her. She lives independently. She's just like a less than a mile from our house. Um, and she graduated from a program at PSU. We were so proud of her. She's amazing. And just would not have envisioned my life any other way, right? I mean, this is just how it is. It's just like I have this daughter, and she's just amazing, and we don't think about the beginnings so much, until you and I had this conversation. I rarely kind of think about these things
Mm.
because it just doesn't come up. We have other struggles in life that life kind of throws us, and we're up for tackling those one at a time. But yeah, no, I mean, I couldn't imagine my life any other way.
Yeah,
Um,
it's such a beautiful
yeah.
story, and through storytelling, I feel like I know you better. I know we've known each other for 20 plus years, but really, it's a beautiful story. I need to let you know something, that when I see a family in the emergency department who is either temporarily or completely adopting a child or as foster care, I actually take a moment to thank them and let them know they're my heroes, because it's hard, even if you're doing something for on a temporary basis, to bring a child into your home that may have experienced physical or emotional trauma is a hard thing. And I think what you and Colleen have done is you've given this beautiful child a gift, and now adult, to become a happy adult and live a life where she feels and is able to give love, which is the essence of why we're here. And I feel even more fortunate to know you, and I know the audience is going to really appreciate this conversation, especially from someone who, when you adopted her, you were in the middle of practicing medicine. It's just such a great story. It really is. It would be a great story for a book.
After the next one's on the way.
That's right.
Yeah. And the gift, I will say this, David, the gift has been ours, for
Mm.
Colleen and I. I mean, again, I just couldn't imagine my life any other way. I mean, there's so much love and so much that she's given us. Yeah, I mean, and her brother, right? I mean, like we're a tight family. So yeah.
Well, thanks for being on the show with me and spending some space and time. And I look forward to um, sharing some time in person. And would really love to have you back on, maybe after the book is published and the second book is published, and we could talk a bit about that. And I have a feeling, I'm not sure, but I have a feeling you have another story to tell.
Thank you so much, David. This has been wonderful, and thank you for sharing your platform and your time with me. This is just, I'm honored. I really appreciate it. And again, it's wonderful to catch up after, a long, long hiatus.
Well, for those of you who are listening, please subscribe on YouTube, Spotify, Apple Podcasts, wherever you get your podcast information. This is David Spiro for HUMED signing off. I hope you all have a wonderful day. Bye-bye.
Thanks for listening to HUMED with David Spiro, MD. If you like this episode, make sure you're subscribed on Spotify, Apple, or your favorite podcast platform. The video versions are also available on YouTube. Make sure you subscribe and hit the bell there so that you never miss a future episode.